We know that mortality rates in Australia from different cancers have declined in recent years, and we're having much better success rates in terms of people surviving long term from a whole range of cancers, including bladder cancer. So these days, rather than seeing cancer as a sort of a terminal diagnosis, we tend to think of cancer as another chronic disease, a bit like things like diabetes or thyroid disease that I mentioned earlier on. So if you have a chronic disease that is cancer, you need to essentially make sure that you've got a treatment team that are managing you over the longer period for that. There can be hassles for patients sometimes navigating complex health systems, particularly if they don't have a close affiliation with a particular specialist or GP who can manage those services for them. For some patients who are managed through public systems, so outpatients, it can be quite frustrating that every time they go, and it might only be for a 3-monthly or a 6-monthly checkup, they see a different doctor who isn't familiar with their condition and is their individual condition, and is relying on a sort of written record or an electronic record. And again, I think if patients are feeling that they're sort of lost within what can be a fairly complex and effective but bureaucratic system, then that's the sort of thing they should be discussing with their primary care provider.
So if a patient has private insurance, they can ask their GP to send them to a urologist who works in the private. Having said that, most urologists will also work in the public hospital as well. And then once a urologist sees the patient and feels that they need surgery of some kind, you can decide with the urologist where you want to go, to the public or the private. If a patient doesn't have private insurance, they can ask their GP to send them to a urologist that works in the public system. And that may be either in a public clinic, in a hospital, or it may be in a urologist's private rooms, who can then take them to a public hospital to have treatment if necessary.
So I guess when someone is first diagnosed, most of the time they would present with some symptoms either to their GP or emergency department, and hopefully from there some scans might be done or blood tests done and referred on to a surgeon. When I meet people, they've nearly always already been told that they have bladder cancer in some way, shape or form. But once they start undergoing their treatment, especially if it's something like chemotherapy, their oncologist does tend to become kind of the centre of the coordination of their care. So we do get questioned a lot about what they should do, even from should I have the flu vaccine or can I safely take other medications? So we'll get a lot of that. So I guess we do tend to be a little bit of a centre point of where for people to go. We're often coordinating being referred to a radiation oncologist, or we might refer them to a supportive care physician to even look at more alternative therapies. And we're getting a lot of requests at the moment about cannabis oil. Yes. And other alternative therapies, and there's a few very specific providers who are trained in that, so we might be providing referrals for that. And often we're coordinating when to do their scans, when to do their bloods. And most of the time we'll try and keep that reasonably simple of what you do need to do between now and the next appointment. So each time they've had one follow-up, they know what to do ready for the next one. When it gets to the point of having some treatment, patients would have the option of either having it through the public system or through the private system. The availability of the treatments is really very similar. I don't see a big difference between what drugs would be available, or the chemotherapy drugs are the same. So the big difference between the public and the private, from my point of view, would be more of how quickly can treatment start. Sometimes there's a little bit more flexibility to get into a private centre quickly. Probably a little bit more flexibility in terms of what day and time of the week they can have treatment. Physical location might be nice. They might have parking, the facility might be a little bit different, but the costs would not be dramatically different. In the private sector, the out-of-pocket costs depend a little bit on each individual person's health insurance setup. So if they elected to have a large gap on their insurance, they might have to pay that gap up at the start, but then going forward, the treatment would then all be covered by their health fund and Medicare. So we set up all of our centres really to have once that excess is paid, there's not gaps. So you don't have every time you turn up an out-of-pocket cost for your chemo. It's really all covered going forward after that.
The important thing for patients with a cancer, any cancer, including bladder cancer that needs treatment in Australia, is that they have appropriate and effective access to services. Many things can affect that access, and where people live can be one of those factors. The reality is that in large regional centres in Australia, they've usually got access to the same sorts of facilities as their families who might live in big metropolitan areas like Melbourne or Sydney or Brisbane as well. But if you live in a small rural area and in a remote area, it can be quite hard getting access to those services. The primary care doctors or nurses that are treating you in those remote areas should have their established referral pathways and networks in terms of accessing services. Having a diagnosis of cancer is always a shock and a terrible thing for a patient. However, it's also something that's recognised that you can't put the investigation and management of these things on hold indefinitely, the way you might, for instance, somebody with arthritis in their knee. So it's up really to the primary care doctor or nurse that's treating the patient to make sure that appropriate access is provided for the patient. So getting them in for appointments, getting them in for the relevant investigations. Those access issues can occur in, even in big cities as well. If you're from a disadvantaged area or there's a service that's particularly scarce, and there's a type of scanning called PET scanning, which isn't available in many centres, and there can be long waits for those sorts of things. But again, the patient at a time where they're dealing with the shock of a diagnosis shouldn't be the person who's having to negotiate that access, and it's reasonable to expect that your health providers are doing that for you.
A lot of rural areas in Australia would have visiting specialists. They might not have someone who is permanently based there. But a lot of oncologists in Sydney hospitals, part of their role would be maybe once a fortnight or once a month going to the larger regional rural areas to provide services there. And then in terms of the chemotherapy, that's often done locally. So there might be at a smaller regional hospital still a small chemotherapy suite or even a radiation centre, but maybe the doctor's not there full time. There may well be a bit more of a delay though between a diagnosis and treatment being done. There might not be a urologist close by, so I'd imagine that most people would get access to a GP, but then to be referred on to a specialist, it might sometimes be travelling to the city to have those things done, or to have their surgery perhaps done in Sydney, and then further treatment might be done closer to home. But there would probably be more delays in terms of people being diagnosed and getting effective treatment, unfortunately.